The end of the pandemic is the start of a perfect storm for surgical overutilization. Patients who postponed surgeries are having them now. Other patients got sicker or fatter during the lockdowns, and surgeons are looking to recoup their losses by doing more cutting. Today's guest, Dr. Randy Hawkins, is here to discuss what his company, Carrum Health, is doing to eliminate unneeded surgeries and offer written guarantees on the necessary procedures that are performed in their centers of excellence. He's also here to share the tale of how he relieved his brother as a medical officer in the U.S. Navy during the Gulf War, and why Carrum's chief operating officer, who didn't serve, gave him a book on naval leadership. I'm David Williams, host of the HealthBiz podcast and president of Health Business Group. Enjoy the show. Well, Dr. Randy Hawkins, Chief Medical Officer of Carrum Health, welcome to the HealthBiz podcast.
David, thank you very much for having me. It's a pleasure to be here.
You know, Randy, Carrum Health is very interesting, and we're going to talk plenty about that. But your upbringing and your background and your career is also fascinating. So I'm going to spend some time, if you don't mind, delving into that. Now, I promise it won't be too personal, but love to hear about what's what. So tell me a little bit about your upbringing. What was your childhood like, and any early influences that have stuck with you?
Fantastic. I'd love to share what I can with you. No one's ever asked me on a podcast before about my background and upbringing, but I was born and raised in a small town in north central Connecticut. My father was an operating engineer of heavy equipment and construction, and my mom was an elementary school teacher for 38 years. Older brother, younger sister, very close-knit family, and my influences were just that. They were of my parents. We didn't have a lot, David, but everything we did have, my parents gave to us, the children, and really afforded us with the opportunity to do what it is we have in life.
No, that's great. I saw that from an early career standpoint, you were in the military, managed to get there, I think, just before Operation Desert Storm, and played a role over there. Love to hear about that, especially sort of the combination of the military and the medical practice.
Yeah, it was interesting. My brother and I were both medical officers in the United States Navy. We got health professional scholarships from the Navy we both attended Georgetown University School of Medicine in Washington, D.C. at the same time, and the Navy paid for it. Part and parcel with that deal is you got to do what they tell you to do when you finish.
Yeah.
And each of us had the opportunity to serve over in the Middle East, and it was so close. My brother's 2 years older than me, David. He went over to the Persian Gulf during Operation Desert Shield, and I was finishing my general surgery internship, and I relieved him on his ship at sea in the Persian Gulf in, I don't even remember when it was, a long time ago.
Yeah.
And I served over there during Desert Storm, and had an enjoyable time doing it. I learned a lot, I grew a lot, and then came back to the United States after the war and served as an admiral's physician in Newport, Rhode Island to finish my naval career.
Now, does your brother look like you? Any confusion?
He's taller.
Okay.
Many would say significantly better looking, but it was. There's no doubt that we are siblings. Let's put it that way.
Well, my brothers, I'm the older brother. My younger brothers are identical twins, and one of them is a physician, and he's actually in the National Health Service Corps, so sort of a similar concept.
Wow.
And his identical twin moved up near the town where he was living, and people would pass him on the street, and they said, hey, you were rude to me, because they didn't realize they were seeing the twin. So luckily they didn't ask him to perform any surgery. He's more of a librarian and a farmer. So, but it's interesting to hear about that. Now that's terrific. And then you also had some corporate experience. One I saw was at Patient Keeper, and my business school classmate and friend, actually, Paul Bryant, was a Patient Keeper, and I assume that you knew him and worked with him along there.
Knew Paul very well, a great man. He was the CEO during my entire tenure at Patient Keeper. It was back, David, during the ARA high-tech meaningful use, trying to get affinity and adoption for healthcare information technology connected with physicians. And that's what we were doing with computerized physician order entry, medication reconciliation products and things of that nature. And Paul and I had a really good run, really enjoyed it.
Now, I remember when Paul, we went to business school together, and then we actually worked at Boston Consulting Group together for a while. And I remember when he went to Patient Keeper, was to be an executive, but he also was a sort of a hardcore coder at heart. And I think he went in there and actually like rewrote a lot of the code himself as the CEO, which is, I guess, sometimes you do, but not always.
I learned that walking in the building. That's what they told me. That was exactly his MO. He really enjoyed, the X's and O's, the dots and bytes, and really participated in everything we did over there at Patient Keeper.
What about Consumer Medical? That's not a company that I'm familiar with, but you played a role there as well.
Yeah, I was the Chief Medical Officer and Executive Vice President of Health Analytics at Consumer Medical for 4 years, directly before coming to Carrum Health. Consumer Medical, 25-year-old company, very well suited in the health navigation, expert medical opinion, second opinion space, really advocating and getting patients off the sidelines to participate in their own care, giving them information, giving them some access to tools, and really building their experience set in dealing with the healthcare system as healthcare consumers. Awesome company, great run there as well.
That's good. Now, Carrum Health, I want to now spend some time speaking about that. Now, first of all, it's kind of an unusual name. Does it have any particular background? Carrum. It's not something I've been familiar with. It sounds like somebody's name or like a carom, like on a billiards table or something.
Yeah, I think it just is rooted in the whole notion of care and revolutionizing the way the healthcare system is set up in this country. The Triple Aim initiative is what we strive for here at Carrum Health, and really changing the level of quality of the care provided, the cost and responsible cost associated with that care, and obviously building highly upon the member experience, which everybody expects in the market today.
Got it. I guess I missed the care part of that because I didn't see the E, but now that you say it, it's of course kind of obvious. So that's good. So big picture, what's the big picture need that Carrum serves to address?
If you were to ask us, David, I think anybody in the building would tell you that it is a genuine healthcare reform, changing that triad for the better. We believe that appropriate care needs to be provided, then high level of care, and then responsible cost. So the opportunity also represents the challenge because we're trying to stand the existing fee-for-service model on its ear and change the way we deliver healthcare, we reimburse it, and we experience it as healthcare consumers. So that's the need.
So there's a big picture kind of an item, if you think about you're kind of responsible for healthcare reform, to do it within one company. And I think even as, the titans that tried to put Haven together, discovered between, JP Morgan and,
right.
And Amazon and, Berkshire Hathaway, that they couldn't really handle it. It's something sort of the federal government needs to do. And of course, they're not going to do it on an individual patient basis. But I mean, do you have a shot at it? What's the approach that you take to make that practical?
The approach that we're taking is to be transparent in our quality evaluation and assessment. Let's talk about that. That was my experience at Consumer Medical, aggregating data, buying data, building proprietary algorithms so that we could sit at the table nationally and agree upon, standardize to some degree, the approach we take to quality. The other thing that's part and parcel to what we do, David, which is important, is this whole payment reform. We have direct bundled contracts with the best of the best. We're not just aligning with brick and mortar facilities, but the individual providers therein, selecting the best of the best everywhere we look, finding quality wherever it is, and then entering into direct contracts with them such that there are transparent, prospective bundles for all the procedures that are performed on our platform. That's really necessary. And finally, the notion of engaging with these consumers. It's a great benefit, but we've got to get folks to take advantage of what we have to offer. And we do it in a very meaningful way. And our Net Promoter Scores and our assessments of the solution by employers and patients really support the notion that we're onto something here.
So Randy, who is a customer? Like, let's take it from the employer standpoint. Like if I were an employer, what would be a typical profile, and who's the individual that you're dealing with? What's their title? What's the pitch to them?
Yeah, great question, David. The large employer groups that we serve, in general, are north of 5,000 to 10,000 employees. They're of that size, of that ilk. We interact primarily through the benefit leadership in these organizations, we become part of their benefit ecosystem, a real trusted partner that integrates in three specific ways: workflow and people, number one; technology through our platform; and then the whole notion of we have preferred agreements with folks where we have streamlined contracting arrangements on our paper, on their paper, and everything in between. So that's who we deal with, and we're really finding great affinity from the progressive folks among us, those who think outside of the traditional forms of healthcare delivery and payment.
So let's say I have a company of 7,000 or 8,000 employees, which by the way, I don't, but let's say if I did, and I've been working with Carrum Health for a couple of years, and I'm reviewing like how it's gone. Like, what would I see as some successes, that I would point to, and what are some of the challenges?
Yeah, the successes would be dramatic increases in quality and reduction in cost, supported by the data. You would see the care delivered to your folks at these top-tier facilities and the top surgeons therein with fewer complications, 80% reduction in complications and readmissions. You'd see avoided unnecessary surgeries at a rate of 30%, and you would see these unbelievable per procedure cost savings of around 45 to 50%.
So, it's interesting if I look across the lines of business or the different areas that you deal with, these are obviously the high priority ones for an employer: musculoskeletal, cardiology, cancer, bariatric. These are a big deal. And it's interesting what you just said about kind of avoidance of surgery, because on the one hand, I think a lot of times people go into it with the assumption we're just going to do it better or cheaper. But a lot of times the answer, I know somebody who has, back pain, they'll say, just if you think you can solve this, I'm into it. But not only that, they might go and they might do physical therapy for a while. They run out of their physical therapy benefit. Then they go and have an extensive procedure. Of course, then they need more physical therapy after that. How do you kind of break that cycle with what you do?
Yeah, great question. And you're absolutely right. The notion of appropriateness has connotation, and avoidance has connotation. Some of it good, maybe some of it not so good. Here's the way we think about it, David. The necessary surgeries need to happen, but not every surgery needs to happen to the full extent of, for example, total joint replacement. Are there lesser invasive procedures that can be performed that are equally effective, less costly, and less cumbersome as it relates to rehabilitation? The other thing is the timing of these high-intensity interventions. Let's say you're like us, you're young and you're healthy. Is it really the right thing if the MRI shows radiographic evidence of osteoarthritis and degenerative joint disease? At a young age, is it really right, even though the x-ray says, to replace that joint? The answer is no. And one of the reasons is the timing, because at these young ages, these total joint replacements are going to wear out, and you're going to have them revised. Let's get you to a point where we're not setting you up for multiple high-intensity interventions. These are all the questions that we ask to break the cycle of, let's just rush to surgery, and then we'll figure it out on the back end.
I've seen people that have had, knee and hip replacements and other procedures there, and they generally have worked out okay. But I think what you're saying makes good sense. There's the other element, of course, that some of the technology for some of those implants and some of the surgical techniques is improving too. So if you can wait 10 years, you might actually get not need to have a revision because you're older, but maybe what you get is your original equipment is going to be better too.
Right. And we look to our providers, the folks that we invite to join the Carrum platform, to be those folks who do two things for us. Of their own accord, of their own volition, they will do the right thing at the right time for each individual patient. But here's another thing we do, David, is every surgeon that comes onto the Carrum platform has to commit to a minimum 30-day warranty for all the procedures that they perform on our platform. And what that does is it aligns their incentives for patient selection, doing the right thing on the right time, because they are on the hook for complications and readmissions associated with the procedures they perform.
Now, do they mind? First of all, that's a very. When I was studying up on the company, I think it was April 1st, and I thought that was maybe an April Fool's Day joke. You had a warranty for a medical procedure, but I saw it there on the 2nd as well, so I assume it's for real.
Yeah, it's a real industry first Nobody else is doing it where they get the physicians to sign up and commit to these warranties, and they abide by these warranties. In contractual language, it is spelled out clearly what are deemed complications that are covered under these warranties. Because we're doing the right thing and selecting the right providers, we don't have warranty claims. This is not a thing that we worry about. It's a belt and suspenders approach to getting the right people on our platform.
Talk about, if you don't mind, some of the differences across these, the different categories between the musculoskeletal, which I'm understanding about, okay, postponed and knee surgery and so on. But how is it different from, cancer on the one hand, or cardiology, or bariatric surgery? Does your general approach work across all of these, or how is it modified depending on what you're dealing with?
That's another great question, because the simple answer is they're very alike in some ways and obviously very different in others. The way they're similar is, as you would imagine, we deal with episodes of care, those things that can be defined by a start and an end. And that allows us to enter into bundled payment contracts with our providers. So they're all similar in that regard. If it's not a service line that lends itself to an episode of care, that makes it more difficult. The differences, David, are as wide and varied as you may imagine. Age cohorts of total joint replacement and some cardiology surgeries and things of that nature are for the older folks among us. But the younger folks are covered in everything from cancer, unfortunately, to the sports medicine components or the outpatient orthopedic surgery components of our bundles with ankle surgery, elbows, things that are sports injury related. And then we're into new and creative and innovative service lines that are on our roadmap with maternity for the younger population among us, and other things in general surgery and behavioral health. So the differences allow for us to tweak the model in support of these individual service lines. Things have different urgencies. Some are semi-elective, preference-sensitive type procedures like total joint. Others are immediate, like cancer care.
During the pandemic, one of the things that happened to hospitals is that a lot of the so-called elective procedures they had to cancel because of the pandemic, and these are some of the same categories that you're working in here. Not everything like cancer is different. What has the experience been like during the pandemic, and anything that, assuming that we eventually get beyond the pandemic, anything that will be kind of a permanent change based on what you did, or is there sort of snap back to, pre-pandemic practices?
Two answers to that question, David. What we saw is what most folks saw, which is a downturn in elective procedures, those semi-elective, preference-sensitive things that I was describing. Unfortunately, even the avoidance of necessary things like cancer screening, monitoring, and care, they took a downturn. We saw that in our business as well. As you would well imagine, the whiplash, the coming out of COVID-19 and the pandemic, is doing two things. We are seeing a genuine whiplash effect in the upturn in the case volumes that we're seeing because elective surgery is back on the schedule. People are more willing to go to the hospital. But the other thing that we're seeing, which is undeniable, is the market receptivity for preparing through centers of excellence and bundle payment strategies like Carrum Health for this onslaught of this backlog of surgeries that didn't get done during the pandemic. Large employer groups are reaching into us and saying, in order to prepare for what's ahead, we really want to control our quality and cost initiatives, and Carrum is the way to do it.
In the musculoskeletal ones in particular, there is a lot of overuse that is widely acknowledged and that you're addressing. And I think sometimes what happens is we were talking before about how, someone just got this pain, make it go away, I'll do the surgery. And thinking during the pandemic that didn't happen. Do you have a sense, or even any numbers, about whether people that, whether the unnecessary surgeries were avoided temporarily, were they avoided permanently? In other words, like, say somebody waited 6 months and like, okay, actually I don't need surgery, it resolved on its own, or even just the idea that avoiding a surgery is not the same as kind of rationing of care. Does it change anything about how people think about these surgeries?
It really does. It makes them reassess, if you will, their current state and current condition, and they have new and informed conversations with their providers. But three things that we notice about the healthcare consumer now that are, again, undeniable is the pandemic did three specific things. It delays, so we have a backlog. We have a large increase in the number of surgeries that need to be performed. Unfortunately, because of delays in care and unwillingness to go to the hospital, few, if any, people got healthier during the pandemic, such that their risk profile stayed the same for these procedures that they're looking to have. So we have a larger number of sicker patients to deal with. And the other thing which folks sometimes lose sight of is, remember, in the fee-for-service model of healthcare delivery, surgeons and hospitals took it on the chin as it related to their top line, their revenue. They are actually, through no fault of their own, looking to restart this engine of doing surgery to recoup some of those losses. And you see it play out in the interesting dynamic of practices outreaching to patients saying, you know, we have open spots in the operating room schedule based upon the now reopening of the hospital. If you were going to have surgery, why don't we go ahead and schedule that and get that done? Yeah. All those factors are working to increasing healthcare cost in no uncertain terms.
Yeah, it's, you know, I actually saw this. I would expect that, like in, you know, let's say San Diego for back surgeries, but I actually saw something from our pediatrician's office in Boston, which was an outreach on the portal for acne consultations, which, you know, they could have an acne consultation, but I really thought it was a little bit over the line in terms of marketing.
Yeah, I gotta be honest with you. I've never seen that one before. Yeah, that is an interesting one. Yeah.
Well, we have a, you know, high-end practice that's affiliated with all the right places, so that was somebody's idea, I guess, of what to do here. Maybe that was the April Fool's joke. I don't know.
Perhaps.
So let me just ask you, you've hinted at it a little bit in terms of what's coming next. It sounds like you're expanding beyond the you know, the areas that you've been covering so far. What's next if you look over the next couple of years? You know, where is Carrum Health headed?
As you alluded to, and as you might expect, breadth and depth expansion is what I call it, David. And what I mean by that, it's obviously bringing in more service lines to cover more conditions, adding more bundles to the hundreds that we already have. Those are necessary and important to us. But it's also the depth of our expansion that's important. Take cancer care, for example. We have multiple important steps in the cancer journey covered: early detection, guidance for any and all cancers, any and all organ systems, and treatment bundles, the industry's first treatment bundles for first-time breast cancer, thyroid cancer, and colorectal cancer. The point is, we need to dive even more deeply into the treatment bundle area and provide these fully packaged bundles for more areas of cancer care. So we want to go deeper and we want to go broad. And the last thing, David, is I see Carrum's network growing even further than it already has. 90% of the U.S. population is within driving distance of a Carrum Center of Excellence. I never want to generate pins on a map so you can look outside your window and say, oh yeah, there's a Carrum Center of Excellence. That's not our approach. But I do want to find the highest quality providers everywhere they are. So we want to expand our network even farther.
Randy, for the last question, I want to go back to more the personal side of things and ask if you've had a chance to do any reading, and if there's any books you would recommend or any books you recommend we stay away from. It's like avoidable reading, right? It's sort of like, you know, some surgeries are unnecessary and some books are unnecessary to read.
Interesting. I can give a nod to a good friend and colleague of mine, Dan Nardi, who's the Chief Operating Officer at Carrum Health. He turned me on to a book some time ago, maybe a handful of months ago, called Turn the Ship Around, written by a retired Navy captain of a nuclear submarine, talking about changing the dynamic in the United States Navy from leaders creating followers to leaders creating leaders. And Dan shared it with me. He had read it. I've since read it. It's an absolute playbook on how to get this right, to empower folks, even in the most critical decisions at war and in, you know, hundreds of people in a nuclear submarine beneath the sea, changing the way people think about how it is they do their job. So that's a great book I highly recommend for anyone in a leadership position or aspiring to grow into a leadership position. That's a great book to read. The only other thing I would say, David, as for reading, I am a massive fan of the literary period back in the day of Ernest Hemingway and F. Scott Fitzgerald. And I read and reread, and if there's only one book I can ever read again for the rest of my life, it's The Sun Also Rises from Ernest Hemingway.
Very nice. Now, does Dan have a naval background, or he just decided a naval book would be good and he'd hand it to you as an old Navy man yourself?
Yeah, he doesn't have a Navy background. I think it was two parts, because he appreciated mine coming into the company. I joined the company last year, and probably no smart part. He probably thinks I'm an idiot, and I need to read the book.
There you go. Listen, whatever it takes to lead the company effectively is great. Well, Dr. Randy Hawkins, CMO, Chief Medical Officer of Carrum Health, I want to say thank you so much for joining me today on the HealthBiz podcast.
Thank you very much for having me, David. Love to join you anytime. Thanks for having me.
You've been listening to the HealthBiz podcast with me, David Williams, President of Health Business Group. I conduct in-depth interviews with leaders in healthcare business and policy. If you like what you hear, go ahead and subscribe on your favorite service. While you're at it, go ahead and subscribe on your second and third favorite services as well. There's more good stuff to come, and you won't want to miss an episode. If your organization is seeking strategy consulting services in healthcare, check out our website, healthbusinessgroup.com.